Hey everyone, it's Dr. Whitfield. Really excited to be back in Austin after traveling for several meetings recently. The biohacking conference hosted by Dave Asprey, and then most recently the Cell Surgical Stem Cell Conference in Las Vegas. Certainly, we picked up tons of what are going to be, I think, great value additions for us in our clinic. We're adding more lymphatic massage with Lopressa, and we're adding Nano V, which helps with improvement in your folding of your proteins and recovery. We also have H-Wave to further increase lymphatic drainage and help recovery as well. So very excited. And then to top it all off, I went back to my hometown, Las Vegas, where I grew up, and I went to the Cell Surgical Conference about stem cells at the WIN. And many of you know I've done several thousand fat transfers, and fat transfers work for a host of reasons. It's your own tissue, which means it's autologous. There's no genetic mismatch. There can't be because it's not coming from another donor or individual like an allogeneic product is. The reason I'm so comfortable with it is I started studying it many years ago. Selfishly, initially, because I was trying to figure out how I could make new cartilage for my banged up knees after 5 knee surgeries. I don't ski or snowboard anymore. Stopped playing basketball a long time ago, and take it easy on my knees. But I thought, oh, if I figured out how to do this, we could get some cartilage for me. So there's still an opportunity for that through relationships we have. But that's a whole different show. So let's go back to what adipose-derived stem cells can actually do. And they can become adipocytes, which are just fat cells. They can become bone cells or osteoblasts, and they're, of course, like I mentioned, can form cartilage. So those are, the three main functions. I think one of the presenters actually talked about they should be able to develop into neural tissue, but that's I haven't seen that in the laboratory yet. So when I get asked, am I worried about development of cancer wherever we do a fat transfer? And so by history, I did many years of sarcoma reconstruction. Sarcomas are tumors of muscle, fat, bone, cartilage. And so these are tumors that are concerning because they're mesenchymal in nature. So you wouldn't put a fat transfer into those areas, or I would not, because the cell of origin is mesenchymal. When we do fat transfers for breast augmentation or breast reconstruction, which has been done for many years, I started doing them in 2005 and had to have done several thousand. So the reason they work, obviously, is you're transferring the patient's own tissue. You have adipocytes, pre-adipocytes, vascular cells. You'll have the adipose-derived stem cells, parasites, if I didn't mention that. So it's a whole mixture of cells that actually get transferred when you transfer fat. And the particle size matters of the fat being transferred. So all things being equal, obviously, we're on the side of alignment where without minimally doing anything to the cells, you can transfer them and they'll have an opportunity to heal. And then, we get asked quite a bit, why can we do the transfer, and how does transfer work? Is it going to last? And so I'll put it, simply. If we were doing fat transfers on people in their, we'll just say 20s as an example, when all things being equal, the hormonal environment is good. There's no thyroid dysfunction. There's no metabolic disease. There's no metabolic dysfunction. There's really what they call homeostasis through, normal hormones or hormesis. Mitochondrial function is good. The movement of a product of fat from one place to another in that patient should be, without question, it's going to work. And so many years ago, buttock augmentation started in earnest in South America, and they went through and have had different time points where there may have been problems, and then in the United States, um, let's just say we'll use Miami as an example. Augmentation of the buttock became very common there. And then several years ago, there were safety issues recorded because there were problems with basically the technical issues. And I wrote a safety paper about that. You can look it up. It's just technical. And now it's, as it should be, it's a very safe procedure to do. So in those patients who are young, who are getting buttock or breast augmentation with autologous fat transfer, you should get very good results. In the buttock, you don't want to put it in the muscle or in the danger area below the muscle, certainly, because that can lead to untoward events. And then in the breast, we're not trying to put the fat into the breast gland. I mean, that doesn't make any sense. It's just going to create a bunch of cysts. So you want to be beneath the skin, but above the breast gland. That's the fat compartment, if you will, on top of the breast. If you looked at it under MRI or mammogram or ultrasound, even you can see this. And you expand that. And I explain it as you can only put a certain amount in this space. So if you think of a pocket on a shirt over the chest, you can expand that pocket or fill that pocket with your glasses or a pen or what have you. And in this case, we're filling that pocket with fat. And then there's only going to be a certain amount of expansion before the skin gets too tense. When the skin gets really tense, you'll see something called podarage, which is just the surface of the skin starts to look like the surface of an orange. That's why it's called podarage. And that indicates that you should not be continuing to expand that. There's just too much pressure. It doesn't expand in the way that when you put an implant in, because it obviously it's a different space, but implants press out because they can hold the shape because of the pressure they can maintain where fat can't. And it's not something that you want to keep adding volume to. So the end game is how much you can put in is a function of where you start. So if someone's super young and their skin is really tight and they haven't had weight loss or weight gain, or they haven't had a pregnancy or something that changed the breast, or maybe they just didn't develop and they have tense skin, you can't put a lot of fat in there at one time. You would do a series of sessions for that type of client to give them more volume, but doing it in a staged fashion would help in that situation. What I commonly get faced with is when I take out implants, which have been in place for a period of time, patients have gone through weight loss, weight gain, pregnancies, breastfeeding. And in those situations, many times the skin is stretched out. And so when we remove the device intact, with its capsular material intact, we're trying to then not fill the pocket where the old implant was, because that's potentially about a third of the time has biofilm in it. We're trying to go in a separate plane of dissection, or what we were talking about beneath the skin, and that's where we place the fat. So that's where it belongs. And then how it heals, why it heals. Adipose-derived stem cells have a number of benefits. They will help, rejuvenate wounds. I think if we look back in the literature, probably wounding, and certainly first and one of the most impressive things I ever saw was reports out of Italy with radiation wounds and chronic non-healing wounds where they took fat and did transfers beneath these wounds and got them to heal. And is it the fat, or is it the stem cell, or all the above? And adipose-derived stem cells have and can differentiate into these other cells. They can have effects on cells around them to help turn genes on. They can produce exosomes. They can modulate your immune system response. So say you're in a really, really pro-inflammatory state, it can actually make you in a anti-inflammatory state. So it can calm that down. They can help with mitochondrial function. The adipose-derived stem cells, which are mesenchymal, they really can produce a lot of interleukins, which can be helpful, as well as VEGF. So there's lots of reasons why if you want to think of it, why a fat transfer is more than just the fat. I would say, sounds a little cliche, but it is a lot more than the fat. It's like the lady from the Wendy's commercial, "Where's the beef?" So here it's just where's the stem cells, not so much where the fat is. The fat's going to go in the right position. The fat's going to heal, and how we're going to maintain it over time is a function of, the quality of food, fluid, and air you put in your body. And then we will have to look at your toxicity, your ability to detox, gut health, super important. Dr. Hazan gave a great talk about the gut microbiome and lack of bifidobacteria, both in the diet and then really in the things that are supposed to be helping the gut microbiome, like probiotics and kombucha. So I did a little thing on Instagram about that recently. So there'll be more to come about that. But certainly we feel strongly about, offering fat transfers, and obviously why they heal as stem cells. We offer to harvest stem cells via fat and have them banked. I get mine every 3 to 6 months is our standard, and I'm due for some actually soon. So we do that through American Cell Technology is our stem cell bank that we use, and then we have a cell surgical device, and then of course I've harvested fat for many, many years. Since 1998, I've been taking fat out of people and moving it from one place to another. So these are all exciting times. I look forward to being able to do more and offer more as it relates to stem cells. All right. Any questions? Hit us up. Send us a comment on Instagram at Breast Implant Illness Expert or Dr. Rob Whitfield, and we'll get them answered. Subscribe to the show, like the show. I have two: the Breast Implant Illness show, and then my show about cosmetics, and then our YouTube channel. Certainly subscribe and like that. We put out a lot of information. Let us know anything you're interested in, and we'll try to get a show done for it.